I would like to bring on our first speaker. We've got two doctors in the house. One will be approaching our discourse from a medical and pathology perspective, while one will go on headlong to the psychology component of sex. And I'm sure at the end of this conversation, our men will applaud MTN for bringing this right to their doorstep, just to say that these consultants are not cheap to see. So seeing them on this platform shows that MTN, in partnership with our HMOs, Midway, has gone the without to pull these consultants here. Thank you so much for making it. So I'd like to introduce Dr. Taiwo Opeyemi Alabi, who is a highly skilled endocrinologist with expertise in laser treatment for urinary tract diseases and reconstructive urology. He completed his fellowship training at the renowned Lagos University Teaching Hospital and is a fellow of the Medical College of Surgeons in Urology. His exceptional expertise has earned him the prestigious Sir Manua Award for the best candidate in the Faculty of Surgery, National Prescribing Medical College of Nigeria. To stay at the forefront of his field, Dr. Alabi has participated in various international training programs and conferences, including Bangalore and New Delhi, India, University of California, USA, Istanbul, Turkey, Morocco, Slovenia, and UAE. His area of expertise includes laser treatment, which involves the kidney, ureteric, bladder, urethral stones, benign prostatic hyperplasia, which is known as BPH, and tumors of the urinary tract, reconstructive urology, urethral reconstruction, hypospedia repair, and pelvic ureteric junction obstruction repair, andrology, which is the male's infertile erectile dysfunction, and other male reproductive health issues, and oncology, which is the centers of urinary tract, cancers of urinary tract, including kidney, bladder, and prostate cancer. I would like please ask and please welcome, with a round of applause, Dr. Taiwo Opeyemi Alabi, who I would say has indeed already treated so many MTN staff and spouses and doctored them on unparalleled. These are cases would have flown abroad in the past, but Dr. Taiwo has successfully managed them in Nigeria, and today some of them are amongst us. Dr. Taiwo, welcome, and please, you have the floor.
Yeah, thank you, everyone. Am I audible?
Yes, you are from my end.
Yes. So I want to say it's a great pleasure for me to be here with you, and thank you for that wonderful introduction. Without much ado, I would like to share my screen. Right?
Yes.
Yes. So I am Dr. Taiwo Opeyemi Alabi, and it's a great pleasure for me to be here with you. On the left of this slide is Dr. Alabi, who is the MDC of Granville, where I work. He's the man behind the vision of Granville and what we're doing in the health space. So this is our center, Surulere branch. It's a multi-center hospital. This is Surulere branch, consulting room, prototype ward, well-equipped laboratory, ICU, trauma center with CT, MRI, and all the other imaging modalities. And we have a young, energetic, and well-motivated staff. So, with that, I would like to start my presentation. So, health, generally speaking, is a state of physical, mental, and social well-being, and not mere absence of disease and infirmity. And when we talk about men's health, we are talking about identifying, preventing, and treating conditions that are most common or specific to men, or that affect men differently than women. And I'll be speaking on the following topics that fall into that category: erectile dysfunction, premature ejaculation, hypogonadism, benign prostatic enlargement, stroke, prostate cancer, and urinary tract stones. So I will be starting with erectile dysfunction. Erectile dysfunction is persistent or recurrent inability of a man to attain or maintain penile erection sufficient for satisfactory sexual intercourse. Every word in that definition carries significant meaning. And I would like to emphasize that new onset erectile dysfunction in sufferers older than 40 years is usually a marker of cardiovascular disease. What that simply means is that in people that are above 40 years who are previously okay with their sexual life and they suddenly develop erectile dysfunction, it should not be taken lightly. It should be exhaustively investigated to rule out cardiovascular problem. And what I mean by that is the vessels in the penis is the smallest, the arterioles in the penis is the smallest in the body, and it is usually the first to be hit by cardiovascular diseases. Okay, so when a patient has erectile dysfunction, more often than not, it is signaling to them that other organs in the body, which include the brain, the heart, the kidneys, and the rest of them, they are also in the process of having problem. So it's more often than not, it's the erectile problem that points the attention of the patient to the fact that there's a problem. Okay, and when it gets to the hospital, more often than not, many of our patients, they get to detect that they are diabetic or they have hyperlipidemia, that is excessive cholesterol in their blood, or they have diabetes mellitus or hypertension when they come complaining about their erection. So I needed to emphasize on this so that we get it. If that's the only thing you get from this, you would have gotten a lot. Okay, so I would like to give us a broad understanding of what's the process of erection. Just think about the penis like a container that has an inflow, inlet, and outlet. Okay, a flexible, expansile container. Okay, like a balloon that has an inflow channel and an outflow channel. So what happens during erection? Erection is a complex neurological interplay of both nervous and hormonal events. So from sight, smell, even hearing, touch, and all of that, signals enters the brain, and from the brain, such signals are passed down to the penis. Okay, so these signals, neuronal signals, they coordinate the opening of the
inlet and closure of the outlet such that the expansile container can now get blown out. It gets bigger because when there is rapid inflow and closure of the outlet, this expansile container, which is the penis, gets ballooned out, and that's when the man has erection. And this erection becomes rigid because there is rapid inflow and there is closure of the outlet, so it's able to now penetrate. So that is the basic anatomy of erection, because I won't want to bore you with the medical details. Okay, so when a man has erection, he penetrates, he thrusts, and when he's satisfied, he climaxes after ejaculation, and then the penis goes down. That is the normal cycle. So what are the components of erectile dysfunction? The components of erectile dysfunction are loss of libido, which is loss of desire. Libido means desire. Weak erection, that inability to have that turgid erection that is strong enough to penetrate. Then premature ejaculation or anejaculation. The causes are many, but they can be broadly grouped under psychogenic or organic. Psychogenic is the commonest, by far the commonest. So 85% of patients who have erectile dysfunction, they fall under psychogenic causes. Only just 15% fall under organic causes. And you need to pay attention here. The psychogenic causes can be categorized into two: generalized and situational. Generalized is depression, things that will affect the inflow, which the bulk of that is at the doorstep of hypertension, hypercholesterolemia, that is excessive cholesterol in your blood, hypertension, and diabetes. So those are major causes of the problem with the inflow. Those ones, they are going to narrow the inflow so that the filling of that container is going to be slow. And when it's slow, sometimes it can't even get filled on time. Okay? And also there are things that can affect the container itself, that is, that can affect the penis. You know, I told you that the container is expansile and is flexible. So some things can make that container not to be as expansile as it should be. So it can make it to be thick. So, and such will include Peyronie's disease, previous diseases such as priapism and all of that, infection. So the organic and the psychogenic causes, how do you differentiate? The organic causes usually starts gradually. The patient starts having noticing problem, and it deteriorates over time. Whereas in psychogenic causes, usually starts suddenly. And psychogenic causes usually situational. That is, sometimes the patient is up, sometimes is down. Sometimes is up with someone else, sometimes is down with the regular partner, and all of that. So there are other differences, but I won't like to bore us down on that. Okay? So when a patient has erectile dysfunction, we are interested in comprehensive history around issues like hypertension, diabetes, also like issue on issue around blood cholesterol, and we run appropriate investigation and we grade. There is this International Index of Erectile Function questionnaire that we use to grade the severity of the disease, and we treat the patient appropriately. So the treatment entails usually lifestyle modification, which could involve exercise, dietary modification, and also medication, changes of medication. Some people are on antihypertensive that predisposes them to erectile dysfunction. We might have to change it to the one that will be more favorable for their erection and their sexual life. We treat underlying disease. Various drugs can be used, vacuum erection devices, and no surgery can also be done, in which inflatable or non-inflatable silicone devices can be implanted in the penis to allow patients to have satisfactory sexual intercourse. So the key points, the prevalence is high and it increases with age above 35 years. It is usually a marker of coronary arterial disease, hypertension, diabetes, and excessive cholesterol, especially in people above 40 years. So the next topic is hypogonadism. Like the first speaker said, hypogonadism is just low testosterone. It is testosterone that is responsible for men's activity, restlessness, and all of that. Virility, the vigor, and the aggression in men. It is the testosterone. So, when there is low testosterone, men, they become slow, they become irritable, they can have loss of desire to have sex. Even when they do, they won't have good sex, they won't have erection. So low testosterone. So this is one of the things we try to interrogate when a patient comes to us. And in people who have completed their family and we have investigated that they don't have any latent cancer, prostate cancer, it's usually easily treatable with testosterone supplements. So the next topic I would like to also talk about is premature ejaculation. So relevant anatomy of ejaculation could be explained by the slide. So if you look at the slide, the whole of this is testis. So the testis, what you release after during intercourse, before your penis comes down, what you release is called ejaculate. When you ejaculate, what comes out of your penis into your partner is called the ejaculate. So the ejaculate is a combination of secretions from the testis. You can see this is testis. The testis produces the sperm, which comes this way into the ampulla, mixes with secretion from this seminal vesicle, secretion from the prostate, and secretion from the bulbo urethral gland. So all these secretions, they come together. They are the secretion that comes out of your penis when you ejaculate, if you look at the arrow. So there are two phases of ejaculation. The first phase is the squeezing out of all these various fluids into the posterior urethra here. Okay? And the second phase is what we call expulsion. The expulsion is this squirting out of the fluid that accumulates in this prostatic urethra, expulsion of the fluid outside into your partner. So, and this is a complex neurobiological event, okay, coordinated by the brain through the release of serotonin, and then the serotonin, the signal is sent to all these organs that I earlier mentioned, and then they affect the expulsion of the sperm. So, what is International Society of Sexual Medicine definition of premature ejaculation? And I want you to listen very carefully.
there are two types of premature ejaculation. There is the type we call the lifelong premature ejaculation, and there is the second type we call acquired premature ejaculation. The lifelong premature ejaculation is ejaculation which always or nearly always occurs prior to or within 1 minute of vaginal penetration. This is what they call 1 minute man in the street language. Okay, that is, if somebody ejaculates always or nearly always within 1 minute of penetrating the vagina, that is a lifelong, that is starting from their first sexual experience. That is the first sexual experience of this person, he was able to ejaculate in less than 1 minute, and it happens like that always or nearly always. That's lifelong premature ejaculation. The acquired type, however, happens in people who have previously been having normal ejaculation but suddenly notice a decline, progressive decline in the duration of their ejaculation to about 3 minutes or less. So there are three components to premature ejaculation. There is the time component, which in lifelong premature ejaculation is less than 1 minute, whereas in acquired type there's progressive decline to 3 minutes or less. The other component of it is that the patient is unable to delay. Once the ejaculation is about to come, he can't delay it and continue to enjoy himself while he's having the intercourse. And the third component is the stress component, because it involves a lot of frustration both for the patient and the partner. It is the time that the partner is enjoying that it comes. It is the time that he himself is enjoying that it comes. So he cannot control the ejaculation. So these are the three major components to it. It's a very, very prevalent disease. Overall, all over the world, about 18 to 25% of people suffer this disease, and it cuts across ages. In Nigeria, the incidence is the same. So, and then the causes are genetic predisposition. Some people are genetically predisposed to it. Then another factor is obesity, traumatic experience, prostatic inflammation, which can come from sexually transmitted diseases, thyroid disorders, and emotional problems, stress, and all of that. So they are being implicated. So when patient comes, we try to interrogate them, evaluate them to be able to know where they fall and how to offer appropriate treatment. So there is what we call intravaginal ejaculation latency time, IELT. That is from the time you penetrate your partner to the time you ejaculate. That's what we call IELT. So we ask the patient to try to time it. Okay, they get a stopwatch. They start intercourse. When they start intercourse, they start the stopwatch, and they'll be able to know how long they last and all of that. And we can use that to evaluate them in the process of treatment, to monitor improvement and all of that. So there are medications that could be used and all of that. So the gold standard of treatment according to EAU guideline is dapagliflozin. So it's a drug that is readily available in Nigeria, and there are what we call psychological stroke behavioral therapies that will also be used. Like, the major problem in erectile dysfunction is hypersensitive glans penis. The glans penis is that cap, the cap of the penis.
So it's been noticed that in people who have premature ejaculation, that gland is hypersensitive. So little rub on it leads to ejaculation. So part of the things that people have done to deal with that is intermittent interruption of thrusting. When you penetrate your partner, you are thrusting and you think you are about to come, you withdraw a bit, or you stop and then you thrust again. You withdraw a bit, you pause, you thrust, you pause and thrust, pause and thrust. That has been shown to, in a way, help some people. Some people can also use numbing agents like lidocaine gel. Rubbing it on the glands may delay their ejaculation, but you see, sex is about enjoyment. If you rub the glands with numbing agent, it's going to affect the enjoyment of the sexual experience. So, but dapagliflozin is one drug that has revolutionized the treatment of premature ejaculation, in the sense that it can be used on demand, like other drugs that are used in erectile dysfunction, like PDE5 inhibitors. So that's the summary. So the next topic I would like to talk about is benign prostatic hyperplasia. So we are no strangers to, most men above 40 years are no strangers to BPH. The prostate is this organ. It's a chestnut-like organ that is below your bladder, and the urethra, which is the pipe that carries urine from the bladder, this is the bladder. The pipe that carries urine from the bladder passes through the center of this organ. So this is a normal prostate, and this is an enlarged prostate. You can see that this pipe, which is wide here, is almost completely obliterated here. So, and that can give you an idea of the symptoms of BPH. And the symptoms include hesitancy, that is, when you get to the loo to pee, when you undo your pants, you bring out your penis, you are supposed to spontaneously initiate micturition. When you fail to spontaneously initiate micturition, then that is hesitancy. And when that happens, you have to strain, as in tense your abdominal muscle to be able to push out the urine, to no avail. The stream of the urine will be weak. As you can see in the picture with this man, the stream is almost hitting his leg, something that is supposed to come. Look at a younger person, is projectile, whereas in this case, it's almost dropping on his feet. So there's also involuntary stoppage of urine. The stream is supposed to come continuously till the end, but when it comes, it stops, then continues again, stops again, and like that. So that's intermittency. Then there's this feeling of incomplete emptying of the bladder at the end of the episode. So there is also frequency, that is, the person goes to the loo almost every now and then. And what is frequency? Is when you go less than 2 hours interval. So urgency is inability to postpone or to delay micturition. Urgency incontinence is when the patient is unable to postpone, but on his way to rush to pee, he involuntarily leaks urine into his underpants. So nocturia is when you urinate more than once or twice at night. So these are features of enlargement of the prostate. If you're having symptoms like that, you need to see your urologist so that it can be thoroughly evaluated and appropriate treatment will be done. So this is my picture when I was doing a procedure to treat benign enlargement of the prostate. So we move to cancer of prostate. Cancer of the prostate, that organ that I showed you, the prostate, can also be involved in a cancerous process.
So the cancer, a focus of cancer can start usually at the back of the prostate, which we call the peripheral zone, and then it can start to grow. And from that also can compress that tube, that pipe that passes through the center, and also create all the symptoms that BPH can create. But what we need to understand is that since the cancer starts from the back, from the periphery of the prostate, before it grows sufficiently to be able to compress that tube, which is the urethra, and create the symptomatology that will alert the patient to the fact that he needs to visit the urologist, it will have been too late. Okay, so early prostate cancer, which is what we intend to pick, they are usually asymptomatic. So they can only be picked by screening, and that's why our annual screening, like I know Leadway usually ensures, must incorporate PSA, prostate specific antigen, because that is what can give us the earliest indication of possibility of cancer in the prostate. So it's a very common disease. Okay, it is the commonest malignant tumor in men above 65, and 1 out of 6 men will have prostate cancer in their lifetime, and about 3% of them will die from prostate cancer. It is rare before the age of 50, and it is noteworthy that it is commoner in blacks, and it runs more aggressive course in blacks than in other races. What are the risk factors? Little is known about the risk factors. If you're going to develop it, you'll develop it. However, what we know for sure is that it occurs in people above 50 years, and it never occurs in people who do not have testes. In eunuchs, it doesn't occur. So you must have a functional testis. You must be above 50 years before prostate cancer can happen. Although I've seen prostate cancer in people who are less than 50, I've seen in 45-year-old, 46, and all of that. So that's why we say that anybody above 40 years must undergo annual screening, which is to do prostate specific antigen. And if your PSA is high, you're subjected to further investigation. What we also know for sure is that prostate cancer runs in family. Okay, and as a matter of fact, there are 2 types of prostate cancer. The sporadic type, that is in people who don't have any members of their family previously affected, is the first in the family. That is sporadic, and that happens in about 85% of cases. There's also what we call the familiar type, which occurs in people with family history. So, and what constitutes hereditary prostate cancer is when there are more than 3 members of a nuclear family affected by prostate cancer, or there is somebody, at least one person affected by prostate cancer in 3 successive generations, or there are 2 individuals diagnosed with cancer of the prostate before the age of 55. So if you ever fall in this category, you must know that the prostate cancer you have is hereditary, and you must tell your children, your male children, ensure that they get screened early. From like 40 years and above, they get annual screening to do their PSA. So prostate cancer starts locally, then it will spread to bone, and so the commonest site it spreads to is the bone. Okay, most especially the bone of the back, and when it does that, it collapses the bone of the back, and the patient will not be able to walk again. So it spreads to the bone of the hip, the chest, and all of that. It has spread. It's been reported to have spread to retina before to cause blindness and all of that. But usually it spreads to the bone, it spreads to the bone marrow, destroys the bone marrow, the patient's blood will continue to be low and all of that. So yes,
Like I said, presentation, most patients, they are asymptomatic, they don't have symptoms. So screening is very key for early detection and possible cure. So that's the picture showing the investigation we do. Sometimes most times when the urologist has the suspicion of prostate cancer, you're going to insinuate his gloved index finger into the anus of the patient or use ultrasound to examine the prostate, and then other appropriate investigation will be done and appropriate treatment will be done. So, and this is me and my team doing a procedure called laparoscopic radical prostatectomy to treat prostate cancer. It's called a KEO surgery. It's one of our flagship procedures in Granville. And after the procedure, after the removal of the prostate cancer, you can barely see the incision. That's why we call them KEO. That's why we call it KEO surgery. They are like keels on the abdomen of the patient. When these ones heal, you will not see any scar. So the last topic I would like to talk about very quickly is kidney stone. Okay, kidney stone, the incidence is higher in men than women, so it qualifies for a topic to be discussed when we are talking about men's health. So the incidence is becoming higher by the day. A lot of factors have been attributed: global warming, and most especially for people in the cities. The cities are hotter than the other parts of the country. So when you're in the cities, you have to pay attention to intake of water. The minimum water quantity of water you take daily should be between 3 to 4 liters. And the calculation is simple. From talking, from sweating, that is perspiration, from urination, and from defecation, we lose about 3 liters of fluid every day. And you need to replace them and even add a little on top for you not to form stones. Anytime you go to pee and you see that your urine is dark, you are setting up yourself for stone formation. And the treatment of stone is very expensive, time off work, and in fact, the state-of-the-art facilities we use to treat stones, which we now have in Granville, they are very expensive. So these are the stones I removed from the kidney of a patient using PCNL. We call it PCNL, percutaneous nephrolectomy. So, and before the advent of this technology in the country, this is the incision we used to use to remove stone. A stone of 1 centimeter, you use an incision of almost 10 centimeters to remove it. But now, what we do is this, just like a pinpoint incision to take care of stone. In fact, some stones, we don't even make an incision at all. We go through the urethra with a flexible equipment that can go all the way to the kidney, to the narrowest part of the kidney, and we use laser to break the stone. So this is what our theater setup looks like. And then I want to thank the organizers of this meeting for inviting me to speak on this important topic that borders on the health and well-being of men. Thank you very much.
Fantastic. Please, a round of applause for our speaker, Dr. Alabi, who has done justice. I was just going to tell him that we had gone past the 30 minutes, and then I saw him saying we have just gotten to the end. Thank you so much, sir, for sharing. Those are consultant level kind of engagements. You have taken us to another level. Thank you very much, sir. But I'm sure I was going to say to people that you should come with your notes and make notes so that we'll have questions we can take at some point of this session. I'm wondering, David, should we just go on to the second speaker because we're running out of time? Because we're supposed to take question and answers after the first speaker.
Yeah, can you? Why don't you just take a few questions?
Okay.
So that people can still gain from this session, and then we quickly, just within 5 minutes, then we quickly take that. Thank you.
Very right. But let me tell you that tomatoes contains lycopene, and lycopene has been shown through various studies to reduce the risk. But anything that has to do with cancer, most of the time they are poorly understood, and the relationship of some of these factors might not be so strong to be preventive, but rather than to lessen the risk. Okay, so antioxidants in tomatoes has been shown to help in reduction of the risk. So you are correct, you are right.
Okay, can we have the second person?
I think that is very controversial, even though I'm aware of a study that was done in Harvard that the person was trying to quote, but he was rather quoting it upside down. The facts, the scientific evidence is that ejaculation more than 20 times has been shown in some men that were followed up over a long period to have some effects on the development of prostate cancer, but the evidence is not conclusive. So it will be wrong for somebody to draw conclusion on that and say that and use that as a benchmark for all men. So the most important thing about prostate cancer is if you're going to develop it, you're going to develop, like we talked about the hereditary component to it. If you're going to develop it, you develop it. So, however, the critical thing is if you develop it, you must pick it early at a stage that it can be cured. So that's the major thing. And also promoting normal, healthy lifestyle cannot be overemphasized. Okay, so that's exercise, intake of water, fruits, vegetables, tomatoes, and all other vegetables. Normal, healthy lifestyle, being active, reducing weight, and all of that cannot, if you have diabetes, get it under control, because diabetes also reduces your immunity, and you need your immunity to fight cancers. You need your immunity to mop up negative cells that are capable of mutating into cancer. So control of diabetes, control of hypertension, dropping of weight, and then exercise, fruit, vegetable, balanced diet, intake of water. Those are basic health rules that everybody should follow. That would be my take on that question.
Okay, thank you. All right, thank you so much. Thank you so much, sir. I think just to balance that equation, I'm taking 2 live questions. I'll take 2 online. How many times per day should a healthy man experience a normal erection without stimulation apart from the early morning? This is now for men who experience erection early morning. Some people report, erections, but through the day there's been no stimulation. So, how many times do a normal man experience erection?
You see, I'm not aware of any.
You're muted, sir. You're muted.
Yes. So there is no scientific basis as to the prescription of the number of times a man can have erection. You see, our bodies react to sensual or sexual signals differently. So, but what we know is that as a component of REM sleep, men have penile tumescence. Okay, so if a man sleeps, he wakes up, he should have some, tumescence of his penis. That is well known. So then, as to the number of times you can experience erection during the day, I'm not sure there's any scientific prescription to that.
All right, thank you so much, sir. Thank you, and thank you to all of you who have posted questions or asked questions. We will have met these questions, but because we're running out of time, may I ask that David, you can put up the profile of the second speaker. While David is doing that, can I ask the men in the house, can you please give me a thumbs up if you're enjoying this session?
The cameras are on.
So there's a large gathering view, but we need a lot of people's camera to be on first. Am I audible, please?
Yes.
Yes.
All right.
I want to say thank you to everyone who came into this session. Thank you so much, staff. Thank you so much, spouses, and of course, men